And hello, everyone. Welcome to Health Watch Oklahoma. We're here every Monday night with the Fab Four, which tonight is Fab Three, and Dr. Chan's home as a musician. So I wanted to tell you this. So I'm talking to Ryan Wilton during the Nocturnal, which is our executive producer's song, right? And Joey had the settings changed in the studio different tonight, and there's a lot more bass, Dr. Chan's home. And I'm listening to this bass deal, and it's on Paul McCartney. So I was, which by the way, I don't know if you saw the 60 Minutes piece on this Peter Jackson deal that's coming out, but another show, another time. Ryan Wilton keyboarded that bass, if you heard that.
Oh, wow.
Yeah.
I don't have very good bass on my computer. I have to listen to it otherwise.
Yeah. He said, I keyboarded the bass, played it with my thumb and index finger. If you haven't heard Nocturnal before, it sounds like a great big jazz bass, and he keyboarded that. It's incredible.
Yeah, that is.
Well, welcome everybody to our music appreciation show. So, just kidding. Dr. Dwight Sublett, Dr. Larry Bookman, Dr. David Chansome, Dr. Armitage on assignment tonight, and got a lot to talk about. At the bottom of the hour, we'll take a break. We'll spend a little bit of time. We had a conversation this afternoon with Jeff Dismukes, the longtime communications guru at the Oklahoma State Department of Mental Health and Substance Abuse Services, talking a little bit about that infrastructure money that's coming to Oklahoma and what it might do for telehealth, and also analyzing mental illness. It's a really exciting thing. We'll talk about that a little bit. We mostly talk about that on Wednesdays when we're talking about the jails and things that we've been focusing on there. But a big show tonight. Dr. Bookman, take it away.
Thanks, Scott. I want to first apologize. I just got into town about an hour ago, flying in from snowy Chicago, where it was coming down unbelievable. I mean, it was a complete whiteout in snow. But on the flight, what hit me first and foremost was the two gentlemen sitting in seats 2C and 2D on Chicago to Oklahoma City United flight, who didn't wear a mask at all. And the stewardess, came up once and said, y'all are really supposed to wear a mask. And that was as far as that went. And they just ignored it and went about their business. And I thought, not that mask wearing on a plane is the most important thing, but I saw tonight we've now passed 350 deaths in Oklahoma this month, 1 month. And these are deaths that can be prevented. We've already talked about how this is a pandemic of the unvaccinated, and a simple thing like wearing a mask on an airplane to help protect others. They don't know who's vaccinated, who's not. I don't know if they were vaccinated or not. But it strikes me that that's sort of where our communities have gotten to, that we have sort of gotten lax about how serious this pandemic is. Vaccines and boosters are out. I think 4 or 5 more states are giving boosters to anybody, not following CDC, but saying anybody can get them. I'd like to hear from the rest of you, Dr. Chansome, Dr. Sublett, what you think about what's the mental attitude of this city, this state, this country on the pandemic. Are we going to have another spike? Many are predicting it, because people aren't taking it serious.
Go ahead, Dwight. I think we've reached a point throughout society of COVID fatigue. I just got back from a trip to Florida, and down there, certainly outside, there was very little, if any, masking, and it was a rather dense population of folks. And I was at Disney. And now they did require it inside, and in compliance there, I didn't see anybody that was non-compliant or fighting the thing. But I think that people are to a point that enough is enough. Our health workers are worn out. And I think the public in general is worn out. They've just kind of gotten to the point, well, what the heck, let's just go on about life, and it is what it is, type attitude. And will we have another spike? I don't know. COVID has been very unpredictable in my mind. We may not, we may, but I think we've got to keep it on our minds, and we've got to keep pushing the vaccine. I think the vaccine is the main key. Hopefully we'll get a treatment that if somebody gets the disease, they can take the oral med, that sort of thing, the monoclonal antibody thing. But I think it's fatigue. That's bottom line. I think people are just tired of it.
I think it's not only COVID fatigue on the person, but it's probably enforcement fatigue.
Yeah.
You see it in the hospital. Nurses don't want to be the security guards for this kind of stuff.
No.
Flight attendants don't want to be the security guards for this kind of stuff. That's not what they signed up for. You see, they landed a lady, or I say lady, a person from, I think it was a lady. It was a gate attendant, I believe, from Southwest that ended up in the hospital and somewhere. Some lady came out and hit her. And it's like, come on, man. It's ridiculous. The question is, I think probably in the back of the mind, the flight attendant is saying something along the lines of, just put on your mask. Don't be an a-hole, and it's, but by the same token, they're like, I'm not really interested. And you know what? Let's be honest. When you're sitting there behind them, Larry, and you're kind of looking up from your book, you're getting kind of mad, right? I've been on the plane before with a guy or a girl or whoever's not putting on their mask. You're like, man, what a jerk. It's like, are you really so important? Are you really so, are you just cooler than the rest of us? Are you just smarter than the rest of us? You got it all figured out and nobody else really knows. Or maybe you're just tougher than everybody else. I think people are fatigued and over it, but I think there's a chance those people weren't wearing their masks 6 months ago either. And, but I get where the airlines are coming from too. You can't, I don't know. It's a tough call. It's all, but I think part of it's probably enforcement fatigue. I try to wear my mask. I remember being on a flight once and I had the mask like this, and the flight attendant would come by, and every time I'd look up, the mask would kind of fall down below the nose. The first thing she'd say is, you got to put your mask over your nose. Like, well, then quit talking to me, ladies. But yeah, no, you just get mad at people who are just, that's like the Aaron Rodgers thing last week, right? It's just smug. It's just smug, and it's just kind of ugly. It's just like, dude, come on. Why are you doing that? It's just, But anyway, so as far as another thing, Oklahoma has always been kind of a secondary destination for COVID. It seems like we've always, I guess Branson was pretty close to us. That was kind of the first place of Delta in the United States, but we'd seen Delta around the world first. We'd seen Alpha around the world first. We'd seen other strains around the world really kind of breaking loose. And we don't hear about that now. But no question, it's endemic. COVID is endemic. We're going to be dealing with this kind of stuff. We kind of have hovered around 400 hospitalizations in the state, I think, for probably the last, 3 weeks or something like that. Is it going to be like that forever? Probably not. But I don't think we're going to ever be down to zero. I think we'll always have 50 or 60, 70 people in the hospital.
Yeah.
And I think that's an important point. While I agree that the individuals who flaunt the rules, who purposely try to, not do what they're asked to do, because wearing a mask is pretty damn simple. They had the mask literally under their chins. They were purposely not doing it. On the other hand, I'm of the opinion that we're always going to have COVID. It's not, people who think it's just going to go away, as we once were told by some of our leaders, it's just going to go away. It's not going to happen. No. It's always going to be here. There will always be some people, whether they're in the hospital or at home. We have better treatments, and hopefully they won't have to go to the hospital. But we're always going to have COVID now. It's going to be part of our lives. And I certainly don't expect to be wearing a mask. And we've talked about on this show how good the filtration system is on an airplane, etc. It's not one of the high risk areas. So, it wasn't that I was upset so much that they didn't wear a mask. or that I know COVID still exists. It's just simply, it's a rule. They talked about it. They told us we had to wear a mask when you get on the plane. And, some people are just, well, it's a rule, so I'm definitely not going to do it. And what are you going to do about it? And that's what I don't like. But I agree. COVID's here. People need to realize it. And I saw an article last week before I left that the Delta Plus, and we've talked about the Delta Plus, and the news made a big deal out of the story. But Delta Plus really hasn't been rampant in really anywhere. It's not overtaken just Delta. And so it really isn't much of a story, but the news tends to gravitate towards something new. And, I think that that's one thing that we all need to be aware of. COVID's here, Delta's here. We live with it, do the best we can to stay healthy, each individual, and vaccination is the way to go.
Absolutely.
I think that's what we need to encourage.
That's the key, and to me, that we've got to get vaccination going. Fortunately, we've got it now for the 5 to 11 age group. Just got the data by midweek last week. In the first week, we had about 3% of that age group vaccinated, around 1 million kids. And so it's getting started, but yet there's going to be, from what we're seeing from the surveys, about a 30% group that absolutely won't vaccinate, or that's what they're saying at this point. But, if we can get 30, get a 60% margin, that's certainly, that if we could get that high, that would be great. And the more, the better. And it's the starting out point in this age group looks really good. The trials are good, and I'm not hearing any glitches at all at this point. It's rolling out smoothly. So that's good news. We just have to keep pushing that. I think that's the answer. And then the compliance is, by nature, is going to drop off. People will just get, more and more. And there's some inconsistencies in the fact that, okay, you go to a restaurant, okay, you sit down to eat. There's people there. You're not social distancing by any means. You got to take your mask off to eat and drink and all that. And yet, but you're required. There's inconsistencies in the message is what I'm getting at. It doesn't always, and it's by necessity. You can't wear a mask all the time when you're, eating dinner. So that sort of thing. So there's some issues like that don't match up real well. So,
well, how about the children? That was going to be my next subject. As I said, more states are encouraging boosters. Mm-hmm. And I don't think any of us would argue with anybody who wants to get a booster. I got my booster. I don't know whether you all have, and had no effects from it all. Couldn't even have told that I had a shot. Certainly had no side effects, and the next day was at work. But what about the kids? Most of the people predicted 25-30% would be, what we would see to start, and that pediatricians were going to be the real key. Are we getting the vaccines to the pediatricians? Are the pediatricians in Oklahoma receiving the vaccine so they can give the shot so parents can talk with their doctor?
I haven't talked to him since I've gotten back, but from what I'm understanding, it has not been a delay in getting it to the offices. I know the health department in Oklahoma County is now running clinics, and the number I heard is they were able to vaccinate around 80,000 kids, or they had that capacity to do that. So it sounds like the vaccine is rolling out much better than the initial problems we had. And it's going to be a little slower than the adolescent, because the adolescents use the adult vaccine, and this is a different dosage. But I think it's getting there. I don't see that as a problem. I'm not hearing that they're having trouble with it.
No, I think at the beginning they said they were a little bit worried about the supply.
Yeah.
I think the demand isn't going to be kind of as great. I think one thing we've seen a challenge with, we got the vaccine. We've already done a few kids. And one of the things we see the challenge with is, it's a 10-dose vial as opposed to a 6-dose vial. And it's a lot easier to get rid of the extra doses when you pull up an adult vial.
Right.
You know what I'm saying? So, I mean, it's, based on, who's coming in your clinic and, you poke your head, but there's not a lot of 5 to 11-year-old kids running around my office. Thank God. Right. By the way, but that being said, I mean, what we're doing is, we're offering it to anybody who walks in on a certain day of the week. And when I had reached out, I don't have kids that young anymore. My brother's got kids, my sister's got kids that young. So I kind of reached out to them and said, hey, and a lot of their friends have already gone to the pharmacies and gotten it. So I think there's pretty good accessibility out there. And, I applaud them for doing that because I think that, again, although the kids are less likely to get sick, they do get sick occasionally and they're still part of the herd.
Exactly.
And if we're going to get herd immunity, you gotta have that's the whole herd.
Yeah. David, with adults, you had your van going around to sort of underserved areas. We still have children in those underserved areas. Our Latino community, our whatever. Do we have vans? Do we have something going to them? Whether maybe it's at the boys and girls clubs or whatever it may be. Yeah,
we do. I was actually at a talk on Thursday at Leadership OKC, and Hallie Reeves from OCCHD gave a very nice presentation on kind of their efforts, and they are really, really looking at because it's just tougher to do a pod with a bunch of 5 to 11-year-old kids. It's so much easier with adults to get them moving through that line. Now, Emmy is doing it, as I understand it. I believe that some of these places are doing those, trying to do as big a pod as they can, but that's just going to be tougher. It's just logistically tougher. I'm sorry. Life is harder with 5 to 11-year-olds. Period. End of story. That's all there is to it. Not that it's easy with 14 and 15-year-olds, but just getting them through the line and getting them, kind of herded together and everything like that. That's just tougher. So I think exactly that, Larry. I couldn't agree more. I think those strike force type of activities. The other thing is, it's a lot easier for an adult to take off work, say, I'm going to go get my vaccine real quick. It's an entirely different thing for mom to take off work, say, I'm going to go pick up my kid and get my kid. I mean, that's just tougher. Logistically, it's just going to be tougher. I don't know that these megapods are going to be quite as successful, although every vaccine is a good vaccine. And so, I agree. I think that we're going to have to continue to look at that. Now, we've reached out to some of the partners we've had in the past where we were doing middle schools and stuff like that have elementary schools to see if they want some help. And we're happy to go do it. I mean, every vaccine's a good one.
Oklahoma County, I heard they tonight that Oklahoma County is doing vaccine clinics themselves, but they're also partnering up with several of the schools around the city. I didn't know if you knew about that, David, but
that's the way to do it. I mean, go to the schools where the kids are.
Vaccine clinics at the schools.
Especially if you're doing it in the pickup line or on the bus. The hard part again is just getting the parents there at the same time, because you can't give an 8-year-old a shot without the parent.
You've got to have
be able
permission
to
and all that.
So the question is, maybe church is going to be a better place. Maybe ball games. Maybe thinking about where those kids are going to be with their folks, that you can kind of capture them in that sort of setting is going to be essential.
Yeah. And you're right. We know that many of these families either have single parents or both parents are working. So doing it during the day, even at the school, although they can send the permit slip home early and hope that it gets back. But the thing that happened when I was a child, I remember, was they had it at night. They'd have the polio vaccine being given starting at like 6:30 at night, and most people got home, and my parents would take me up there and we got the polio vaccine. So those are things that really need to be thought about. How do we open it up, whether it's at the school, whether it's at a church, when parents are able to bring the kids up, and certainly trying to have permission slips that maybe the kids can take home. They used to pin things to us.
Yeah,
send them home.
I don't know if that's going to fly anymore. I mean, I used to. You remember you had come in school, you look like that.
Yeah. So
I don't
yeah.
know. I don't know. I believe for 16 and 17-year-olds, you had to have the parent there at the beginning, and then they changed the consent a little bit, particularly since there were so many follow-ups, and obviously a lot of those kids can drive themselves and get themselves there. It seemed like the consent changed afterwards to where you could have a parent sign it and the kid could bring it. But at the beginning, it was definitely the parent was there. And I imagine for, now for 12 to 16, I can't remember what the consent there says, but I'm pretty sure they had to have the parent present. And we have certainly done that. I mean, I just,
You want to do that. Yeah.
It's just, in today's world, I think you have to do it that way.
Yeah.
That's okay.
Certainly having it when they can come, though. Having
No
it
doubt.
9 to 5 is
convenient.
makes no sense.
It's not going to work for most
Not
of them.
going to work.
And that's why, again, I think that's the Saturdays and Sundays are really where you're going to have to try and make a little money. It's where you're going to have to try and get some of those people, again, at the soccer fields, at the baseball, at the basketball gyms, at the places like that, where maybe you can you have a chance to get those kids lined up.
One of the things that was brought up last week in our post-game discussion was long haul. And we've not talked at all recently about the long haul, especially in kids. Are we still seeing it was around 30%? Is that still an accurate number? Dwight, I'll start with you with kids. What are we seeing from the long haul with our kids, both the teenagers as well as younger?
Total. Okay. Well, I'm looking at 5 to 11-year-old data. 5,200 cases of inflammatory syndrome in that age group. I don't have in front of me the total from 0 to 18 in front of me, but as far as the numbers, I don't think that has changed. I don't think it's increased a lot. Hospitalizations increased, obviously, with Delta big time, about 5-fold. We went from 16% to around 26% at one point there, and that sort of thing. Deaths remain low, relatively around 1,000 deaths total, but they found that with the vaccine, they didn't see any inflammation. They have not seen any. I have seen no evidence of a significant problem with mortality with this. There have been some deaths. I think 14% of all the deaths was from this, but it was not the major cause. Most of the deaths were due to underlying conditions, obesity, asthma, developmentally delayed kids, and that sort of thing, congenital problems. But I think it's kind of been in the background. It's there. We see it in a few kids, but it's just not blossoming out to be a major issue.
I think the hard part is we still haven't defined it. Is long haul COVID start on day 30? Does it start on day 60? Does it start on day 15? I mean, and then
how long does it last?
And then what are the symptoms of it? Right. What's an acceptable symptom? I can't run a marathon anymore. Well, you just had COVID. I mean, that's kind of understandable, but there. If you look at it, there's all kinds. I could see it being almost like IBS, where you have several different categories of IBS-C, IBS-D, IBS-B, IBS whatever. Because there are so many different protein manifestations of it that can be very difficult to discern. I mean, one person might have persistent diarrhea, another person might have persistent anosmia or persistent shortness of breath. Everybody's different, and right now there's just one big, huge wastebasket. Not all long haul COVID is the same. Right. And if your problem is joint or muscle pain, we're going to rehab that differently than somebody who's short of breath. So I think there is still a lot of science there. But Larry, I agree. I think the numbers are still 25 to 30%. But again, what I mean, I'm still sick after I had COVID. I didn't get better right away until we really define like we do with other diseases, right? We do this with all of our other diseases, like we do with other diseases. You got to define some things here for us to be able to really put them in the right category.
Yeah, I compare it more, and for our listeners, they may not understand this, but I compare it more to lupus.
Yeah, I agree.
Went for years where everybody had lupus, but there was no definition, and everybody had different symptoms. we may be a little better. I still think we're
It's
sort
still
of
pretty
all
tough.
over, all over the place.
Still 4 out of 11, I think, is the same score, isn't it?
Yeah.
I don't know, but yeah.
So we need to really have the science done. We've been doing this for 2 years. We've got the scientists. We need to get things really honed down, defined, and then get the public and physicians educated. Because I can see physicians out there, somebody says, oh, I've had a headache, and I never used to have headaches like this. Well, you've got long COVID now. And is that going to be disability? I can see disability claims coming.
You're right. You're right. That's probably where the definition is going to come from, isn't it, Larry? It's probably going to come from the workers' comp industry, like it has in the past.
It may.
They're going to say, "Hey, we need some metrics here." And that may still be 30%. I don't know. But they're going to have some metrics to figure this stuff out. The insurance people are.
Yeah. No, I agree, and I just think our scientists need to be honing down on that and really giving us solid information.
Well,
it's hard to find.
I'll give you an example.
It's hard to find.
In my world, as a member of the Infectious Disease Society of America, it's been Lyme disease. And there were many people who just got a diagnosis of it, test or not, because the tests aren't very good, who got a diagnosis of it. And we had trouble discerning, who needs treatment, who doesn't. Antibiotics don't really work anyway, but we in the IDSA, they came out with very stringent diagnostic criteria. Well, they're taken to court. They've been in court for the last 15 years for it. Is that same thing going to happen here? It very well may, where it was, well, my doctor, my practitioner just said I had Lyme. Well, but that's not good enough. You got to have we're scientists. We have to have some metrics here. And I think the same exact thing is going to happen. So it has to.
Yeah. So my advice to people who may be listening to this is, just because your physician says you may have long haul, you might have symptoms related to your COVID, we don't know at this point. And I think that's important for physicians to often say, I don't know. We don't know what the symptoms are going to be long term. We know that there are people who have long-term symptoms. No doubt. We don't have it defined. And so I think that's important for people to understand.
And I'm even hearing that people are having symptoms in a sporadic type fashion. They seem fine for a while, and then all of a sudden I'm starting to have the same sort of things I had before, but they're not active disease. So there's a lot of unknowns.
A lot of unknowns.
Well, let's go into another subject we've talked about in the past, but I heard tonight of an outbreak of flu in Michigan, more than 300 cases in 1 week in one community. And what are we seeing here?
They had a huge,
David?
Now I heard about it. I was reading about it on my ProMed thing, and I think they had they had 300 cases last week, but I think they had 200 cases a week before too, and a super high positivity rate, like 35% or something ridiculous like that. We're in a heavy flu season when over 10% of people with influenza-like illness are positive. So 37%. That's a full on, that's a full on thing. But the strain is an H3N2 strain. It's not, an H1N1 or anything like that. There is an H3N2 strain in the flu vaccine. I had read about 80% of the people who tested positive were not vaccinated. So, there's that too. And people have kind of been maybe forgetting about the flu vaccine. Flu didn't go away. It's been here for a long time. Since 1918. It's also one that was a pandemic that became an endemic. So, and then you'll see, this is just going to be such a cool case study in what's going to happen with COVID, because this is what you're going to see. You're going to see little pockets of COVID once it's endemic like this. Every now and again, something will pop up, and all of a sudden you'll have a 40% positivity rate at wherever. So that's going to be the same thing that happens. So, but it's important to get your flu vaccine. It's important to get your flu vaccine. And remember, I get this every single day in my clinic. I didn't think I could get them both on the same day. You can't. Your arm might hurt. You might feel a little cruddy. but you can get them both on the same day.
And for the kids, you can get your routine vaccines along
Right.
with your COVID. So don't
Right.
delay your routine vaccines.
Now, there are still some vaccine rules about live viruses and
Yeah.
everything like
Yeah.
that. Those rules haven't changed. But
No,
as far as the COVID vaccine impacting vaccine schedules, it shouldn't at all.
should not.
And the point of my bringing it up is to tell people, get your flu vaccine.
Yeah.
They're available. Get the kids the flu vaccine,
Mhm.
get the adults the flu vaccine, because we're into flu season. And, there's some question whether we won't have the antibodies that we once had because of masks and distancing. And a lot of people didn't get the flu vaccine last year. And all of those are going to come into play. And the flu season may be a bad one this year. So,
Mhm.
But here's what's going to be fascinating. I know I'm switching gears here a little bit. I apologize. But with the messenger RNA rollout that we've had with the COVID vaccine, I mean, believe me, they're going to start looking at messenger RNA for everything.
Mhm.
And
Yep.
because the technology is just too fantastic and too simple. But the question is, are we going to start seeing, when there's an outbreak like this, all of a sudden a messenger RNA vaccine come in for H3N2 targeting the exact strain? Because just because it's H3N2, you could have H3N2 this or H3N2 that. There's still subtle differences in the antigenic drift. And so it'll be fascinating to see whether or not that's another platform where you could deploy something like this
Mhm.
in a rapid fashion that would provide some protection kind of at the point of attack.
So tweak it even during the season.
Just like that.
Wow. That's going to be neat to have that.
Isn't it? What a
Yeah.
tool.
I think that's a great point,
That's
David.
cool.
I hadn't really thought about that,
Yeah.
because I hadn't thought about the messenger RNA vaccines.
Yeah.
But you're right. That's exactly where they become
Mhm.
so important,
Mhm.
and absolutely great technology.
Yeah.
So
Some years we don't hit it very good as far as what we got in the vaccine versus what we see.
Exactly. And that's what I'm
So
saying.
if you can
It's
shift
so
on the fly,
rapidly
that's
deployable. Do you guys
Yeah.
remember? I mean, do y'all remember? I guess it was 08 or 09, maybe 10, when the
Yeah.
H1N1 strain hit in the April, and we all
Yeah.
had to have that second
Yeah.
flu shot. It was that late surge. But that was an H1N1. That was a totally different deal than what we'd had in the vaccines at that point in time. Now, usually
Right.
keep an H1N1 and H3N2 and 2B
Right.
and the quadrivalent. So, but I mean, I've heard about a fair number of activity of B even in the community already. So, who knows? Here it comes.
Here we go.
This is what we want.
but messenger RNA could, in the future,
I think
make all of that, unimportant, because they can make the vaccine quickly, get it out directly at whatever they're seeing, and not trying to
would be
guess
so
about it.
neat.
I think so.
Yeah.
Yeah.
I think people need to understand messenger RNA is the future.
I really think it is.
It's
think
the
it is.
present and the future.
Yeah.
So,
And not just for infectious diseases. I mean, you got to remember, a lot of that messenger RNA technology was originally deployed for brain cancers and glioblastomas and things like that. I mean, it's
Maybe in
not just going
oncology.
to be
Mhm.
for vaccines. It's going to be for anything that you need proteins for anything that you need messenger RNA for. So it's going to be a fascinating next 50 years to see what happens. So
yeah. Hopefully we'll all be around for all of it.
you have to get enough messenger RNA vaccine in it like this.
So, we saw today the president signed the infrastructure bill. All kinds of things related to medicine in the infrastructure bill. Yes, it relates to bridges and roads and all of that. But one of the big parts of it is some 620 square miles of Oklahoma. Much of it doesn't have broadband. And if it does, it's really poor broadband. The bill has more than, I think, 60 billion, something like that, for broadband. I know there's a big chunk of money. Scott, you've got a video on mental health, but broadband goes into education in our rural communities for our children. That's going to increase or improve Oklahoma health, and that's what we're trying to do here. Mental health, is important. Broadband's going to help that. So what does the mental health department think about the new infrastructure bill?
I think it's a lot of money. It's interesting because Wednesday night we'll have a little bit of video with Logan Phillips, who's a state rep, who's handling the broadband bill for Speaker McCall. That was their big thing a couple of years ago. So there was already broadband money on the way to Oklahoma being deployed by Oklahomans with some of the money, some of the ARPA money that's been going on. So now comes the infrastructure bill. There was a really good article a couple of weeks ago, our friend Trey Savage over at Non-Doc, and it was out in eastern Oklahoma. One of the counselors out there is saying one of the problems we have on mental health, for example, is we simply do not have enough broadband. So they can do diagnoses, they can do screenings, all kinds of things on telemedicine. And so I had a brief conversation this afternoon with Jeff Dismick. So regular watchers of this program know Jeff. He's the longtime communications guru at the Oklahoma State Department of Mental Health and Substance Abuse. So I've got about 3 bites here, Dr. Bookman, about what he said about this infrastructure bill and mental health, which, by the way, 6 months ago, just before Delta had its party, all 4 of our doctors were saying to me, we got to spend more time on mental health because at that time we thought COVID was doing it, and it was.
And it still is. Yeah.
By the way, we're going to have a quiz before I get to this. Late in the show, we'll give the answer. 6 of the top 60 countries in terms of vaccine percentages, where is the United States? Well, let's see if you can get an answer on that. Just send me it. Dr. Sublett already knows. He's already.
No, I think I've got it.
So how do we rank in terms of vaccination of our population of the top
out
60 countries
out
in
of
the
the
world?
top 60 out of the top
60.
60 nations, where does the United States, just in terms of where we're at in Brazil? Don't say yet. We'll get to it.
All right, so everybody put their answers in the comments, and Larry is going to give no.
Well, here's what we'll do.
Okay, you got to come
butter,
up with a number. You can't just say low. You got to come up with a
Low.
number.
Which out of 60,
Guessing
you
the
got
jelly
like,
beans. Come on.
Yeah.
are we 1? Are we 10? Or are we something else? So, and I have a feeling we could get Dr. Armitage to supply for the winter Nutter Butter peanut butter sandwich cookies.
Ooh.
That's right.
Oh.
We can.
Ooh, I'm
We can
in.
get him
I'll
to do
in.
that.
No
And,
cheating.
and,
All right.
and let's give them a hint.
Let's do
We're
it.
not number 1.
They're not number
No,
one.
not number 1.
That's the only hint you get.
But I don't
And
think
we're not
we're
last.
60.
Okay, how's
We're
that
not
for
last.
we've given
Okay.
2? Not first, not last. All right, so come up with an answer. All right, so here's Jeff Dismukes. We couldn't be together today. He was off in another state working on something, but this is what I asked. I asked him about if he's had a chance to see what was in the bill, which, by the way, Logan Phillips, to his credit, in an interview about 2 months ago, I said, look, and he's a Republican, by the way. I said, all of the Republicans are going to vote against it, but the money's still going to come here. Are you going to, spend the money? He said, every nickel. So anyway, being honest about it. So here's Jeff Dismukes talking about what, on mental health at least, and telehealth, what the infrastructure may mean for people in the state of Oklahoma.
Yeah, I think there are a lot of opportunities right now with the use of technology. We've really seen some things over the last couple of years, especially. And it's one of the things that really came out of COVID was trying to figure out new ways, innovative ways to make sure that we get people into services. So the use of telehealth had already been something that we were really doing in Oklahoma and had been moving forward with, but we've taken that to a new level now and being able to expand those services, particularly in rural areas, because we've always known that it's difficult in Oklahoma to reach people in those rural areas where it's you might not have the ability to support freestanding services, so that we can reach out a little more, get people, this is something that's really kind of exciting about it. It's you're able to really link to people who are in need when they're in need and help navigate them to the right resources. Because, let's face it, some of the things that have happened with behavioral health is, as far as barriers, has been with people not knowing where to turn or not being able to access those services when that moment is there, and especially on, let's say, addiction issues. And we're able to use telehealth with addiction issues also, and get people there when it's that time. So I do think it's really an exciting time right now. Opportunities for innovation, anything that we can do to expand those services in those areas is absolutely fantastic. And and I need to say too that is something that has been embraced by our elected officials in this state. They've been talking about this for some time and really moving forward and making investments in those services.
Thoughts?
I mean, we have seen telehealth be such an important part of the pandemic here, but I think, I'm a pretty highly specialized infectious disease doctor. I mostly just do musculoskeletal infections, and my patients are from all over the state and from outside of the state. And I think we still have, is it, Larry, you would know better than I would, 27 counties that don't even have critical access hospitals. So, I mean, for my poor patient who has to drive down, I mean, I had a guy today from Guyman. He had to drive 5 hours to come and see me for a pretty short visit and then drive all the way back. Is that, and he's got a bad leg. So telehealth is huge. For mental health, it's even bigger because those people need to be seen 2, 3, 4 times a week sometimes if they're in crisis mode. I can tell you, Indian Health has been doing telepsychiatry for a long time. I got a good friend of mine who's a psychiatrist over there, and they have been doing it for a while. I mean, there is real value in that. But I got a ranch down in Murray County, and I get 2 megabytes per second there. You can't do anything with that. You can't do this. No. There's no way you can have this back. Now, granted, I live in Oklahoma City and I just got cut off 20 minutes ago, but that was a different deal. So it's going to be a huge deal health wise, especially mental health wise, but also follow up wise. I mean, how many, just think about compliance visits for medications. You don't have to have a nurse go to the house now. Maybe you can just have a Zoom visit and say, hey, let's walk through your insulin real quick. Let's walk through your little pill box real quick, because that's a really, really big part of post-hospitalization follow-up to try and keep people from coming back into the hospital. Do you know how many people come back into the hospital after they've just been discharged with congestive heart failure because they're not taking their medications correctly when they get home? That's a very, very common cause of readmission. That costs all of us lots and lots and lots of money. To readmit those people. So I think this is going to be a huge, huge, huge deal, just health-wise. There are several services now. Oklahoma, one of the first, has had a very, very robust telestroke program where people can call in from these small hospitals out in the rurals where they may not have neurology on call all the time and see a neurologist face-to-face who's sitting there asking the patient to do this and do that and diagnosing them with a stroke over the phone because time is of the essence. There are places that may not have access to that because of this. So I think the broadband stuff, don't poo-poo it. It's a big, big, big deal.
I think in the pediatric world, it's going to be nice. I mean, if you've got, say, a 2-month-old out in Guyman, for example, and their pediatrician, they're driving over to Enid for the pediatric care, and the child is sick. Well, you've got to try to make a determination. Is it time to get in the car and head this way, or can you kind of do a site evaluation? No, it's not hands-on. It's not perfect, but you can certainly get some ideas of where the child is at that point and how much concern there is. So I see uses there, and certainly for developmental screens, things like that. I think it's going to be a big help for us.
It doesn't work for everybody. I mean,
no.
Julie on here from Rain has, a great point. She serves a lot of HIV clients, and we see a lot of our HIV patients over telemedicine now. I've got people all over the state with HIV, and HIV is largely a maintenance type of visit, right? I mean, they are pretty good. They're usually pretty stable, and you can tell a lot of stuff. There are some things that it's not good for. I don't really care for seeing my post-op infections over the telephone. I need to look at the wound. I need to smell it, talk to the patient, see is there warmth? I mean, there are things like this. It's going to be tough for Larry to do an abdominal examination over the telephone. It's just not the same. It's not the same that we learned how to do. No. So there are some things. But as far as a triage tool, like you're saying, right? I mean, you get in touch with somebody and you say, "Oh, that kid looks kind of sick. You might, need to take him down or whatever." That's a real thing.
It's going to be helpful.
Yeah.
Well, I think that there's a real broad subject that we need to make sure everybody understands. Number one, yes, in specific areas of medicine, and we've used broadband for a long time at Integris in the cardiology sector, where
Uh-huh.
acute MIs,
Uh-huh.
you know, they can get to a cardiologist here who says, do this, do this, do this,
Right.
and he can see all the information. That's one aspect of broadband that needs to be in every community. But even more important than that, mental health, absolutely. We've used telemedicine and mental health for years, and it's been the only thing that really was used in telemedicine. But again, many rural communities just don't have the broadband to be able to use it. So it's going to help that. Even more important is the education. Kids being able to get programs, to get education. Our children in rural communities, poorer communities, communities without the ability to have even a computer, the broadband to be able to get on the internet. That's huge. In Oklahoma. I was on the governor's transition team, and that was one of the things that I was in specifically in charge of, was about broadband. And we brought this up, and there's a bill that, you know, has been there to get money to Oklahoma before this one even came up. But this is going to make a huge difference to the state if we only are smart in how we use it, and we get the people to understand that our children can benefit greatly from this, far beyond cardiology, far beyond mental health. This is the education of our children.
Yes.
And without that, education leads to better health. It's real simple. Yes, it's not going to happen today or tomorrow, but education will bring in better health for the state of Oklahoma. So, Scott, you've got another clip, and then I want to have time for questions. So
I do. Here's a couple. So Katie Mitchell. So the prisons need expanded treatment. So that's a good. Let's go into this clip. This was the clip that Jeff was talking about. Oklahoma City and Tulsa have two ginormous, I think is the term, facilities that house prisoners. Tulsa's a lot. I think a lot of observers are going, Tulsa may be doing it better. We had Commissioner Mon a couple of weeks ago talking about things that are getting better at Oklahoma at the detention center here in terms of facility. They're trying to work, making some gains down there, which you don't hear much in the press. But nonetheless, this is what Jeff had to say about telehealth, this expanded broadband, what we might see in terms of folks in correctional centers that deal with mental illness.
Well, you know, one of the things, and I mean, with us talking about innovation, one of the other things I think that's happened is a lot of innovation at the community level, particularly around criminal justice issues. You know, Oklahoma City's been talking about this for a number of years, as has Tulsa. There's a lot of energy around this and trying to find solutions where behavioral health impacts incarceration. Certainly, we've invested over the years. A lot of people know about drug court and mental health court, but there are other services that are being delivered in Oklahoma City, Tulsa, and throughout the state around those types of programs where you're able to divert and engage people in treatment when that's the correct thing to do. The other things that I've seen are some real partnerships to figure out how to really engage that population. So substance use issues are big within as far as the incarcerated population. And there are some things at Tulsa, for example, where they have been able to engage people in services, utilizing some of the things that we brought into the state in the last few years, medication-assisted treatment, for instance, where they're able to start those services in a jail setting and continue those services as people exit the jail with the providers there in the community. So, you know, there are just many opportunities there. We are seeing different things now and opportunities to maybe engage in more competency services in that jail level, to maybe start those services a little earlier when the courts determine that that's necessary. So I think there's a lot of energy around trying to get those services to those individuals who we see especially frequently incarcerated because of their illness, and move them into a positive structure to where we can stop that recidivism and help them get their lives back on track. And that happens every day. I'm really fortunate in that I've been able to see a lot of this and see lives change over the years. And it really gives you incredible hope. Often what we end up talking about are those negative stories, and that's what kind of stays with people. But you and I have talked over the years, and certainly there's been on your part a lot of effort to try to get this out. The positives outweigh those negatives, and it's important to talk about that.
Anyway, that's the last bite for the evening, but just a tease of what we've been working on Wednesdays. But what he's saying is that a lot of this, there's going to have to be a little more focus on corrections. And these are not the sorts of stories that can be done in 90 seconds.
No, mental health is a grind. It's not something that's going to be able to be fixed quickly. And but we're more important to deploy it than places like that. I mean, more certainly, it's going to have a bigger impact than anywhere else. And you have a population that you can get to 3 or 4 times a week pretty easily, particularly if you have these kind of services that are there. Is Jeff remoting in from the set of Dune? It's kind of a interesting orangish hue in front of him when I'm watching the video.
And it was he was in Minneapolis, Minnesota.
Minneapolis.
That was like very late in the day. So I don't know what. I guess they're on the same.
I think I'd rather be at Dune.
I think so too. Minneapolis. I mean, it's where the Vikings are. Oh.
Ugh.
I'm sure the snow I hit in Chicago is affecting Minnesota.
Minnesota. Yeah.
70 degrees here, and it was 32 there. So
But at least the Bears play outside. The Vikings went inside, and they haven't won anything since they went inside. You ever notice that?
yeah.
Good point. Still on Soldier Field, aren't they?
Yeah.
That's a fun play. You ever been to a football game there?
I have.
It's a fun place to watch a football game.
Unless you're wearing lots of Packer gear.
Packers win. I don't know. Is it always more fun to go on the road and watch your team? I mean, Waco probably wasn't fun this weekend, but I mean, it's like I when the Thunder were in Miami playing in the NBA Finals, we went there and watched the game. I mean, it's always fun to go on the road and watch your team and be the underdog, be the minority.
We can talk about mental health in the OU team.
Oh my goodness. You know what?
Depression.
Let's be magnanimous. Texas needs our help way more than Oklahoma right now. We need the broadband to get down to Texas.
Did you see the picture of Matthew? Did you see the picture of Matthew McConaughey?
No.
They posted. It was on, I don't know, YouTube or something. I don't know. He was a sad boy that day, I'll tell you.
I'm not shedding any tears.
Yeah. I know.
I mean, that was
too bad.
Too bad.
I was texting with Ruskowski that night. I said that the Texas loss is an excellent salve for the wounds of the OU game.
That's right. Yeah.
Like, I'm really miserable, but it could be so much worse.
What questions do you have, Scott? Do we have any from?
Well, let's see. There was one a little bit early. I have to scroll back up. A lot of great comments tonight.
A lot of great comments.
So there was one about something that's being done. Oh, here's Brenda Carpenter said a few minutes ago, what do you think about the zip code and city level COVID data being removed from Oklahoma State Health Department's website?
I think a lot of that probably just has to do with trying to deploy their resources the best they can. All of that data takes a lot of time to put together, and it takes a lot of manpower. I think it is super helpful data. I have really, really liked it. And we were on at that leadership book AC thing, Hallie was going through, kind of how they compile it and everything. It's just fascinating, Shula, their epidemiology type stuff. But it's time consuming and it takes manpower. And Oklahoma State Department of Health has certainly been stretched thin. I'm sure they've had a fair amount of attrition. And with, COVID calming down, certainly not going away, but calming down a little bit, maybe they can deploy some of those resources to other things that need to be done. Getting more flu vaccinations out there, making sure our kids are vaccinated, all these kind of other things that they have to do. I think that's really it. I don't think it's any sort of attempt to hide anything.
And it may need to be ramped up, and
exactly.
We may ramp up again. It doesn't mean it's always gone. Yeah.
Here's another one, Dr. Bookman. You ask. Robert says for you three, how would telehealth increase access to health care for prisoners?
I think what it would do more than anything is provide more opportunity for physicians to be incentivized, or practitioners, counselors, psychologists, whatever, to be incentivized to doing it. You're right. I mean, maybe they already have really good internet, but I'm guessing they don't in all the prisons. But certainly there's a lot more that goes into that than just the wires. You got to have the computers. You got to have the nurses to give the medicines, everything like that. So that's good. That's a good point.
Yeah, and I think mental health is the main aspect for the incarcerated. That's really what they're after. And we have prisons in southern half of Oklahoma, so there is not internet in all of them. It's not just the Oklahoma County and Tulsa County.
I think having on-time healthcare. I mean, I can tell you, I didn't do it in Oklahoma, but when I was a chief resident, I used to go once a week to Orleans Parish Prison, and right down there off Tulane Avenue, and go administer healthcare for a half day a week. The chief residents, we all rotated through there, and they would have people that were sick for 3 or 4 days waiting for the doctor to come in. Having telehealth availability, having healthcare availability at the point of even a nurse visit for that, because there's always a nurse in the larger prisons. Having that backstop for the nurse would be a big deal to make sure that we're taking care of the prisoners and respecting their rights.
KD says some inmates have iPads now. It's limited access, but they could get counseling.
Wow.
Yeah. KD, where are these iPads? Where are the inmates at? If you're listening, if you give us an answer where that's at.
I was going to say they're not allowed cell phones. I'm amazed they have iPads.
Is that right? Is this like minimal security type?
Oh, maybe. I don't know.
She says limited access.
Yeah.
Yeah,
it's weird.
I don't know. What else?
She says in Boley.
Boley, America.
Boley, America.
This is a whole show. I mean, how does Medicare handle this? What would you need infrastructure? You know about these prisons. I mean, these things some of them are so antiquated. They would shut the one down out in northwest Oklahoma. They couldn't get the locks to work out there.
Right.
So many of these buildings, they are simply past being able to be, to get locks to work. So how are you going to wire them up, right?
Yeah.
And of course, there's umpteen billion dollars in this infrastructure.
Ruskowski brings up the good point. We got to keep pressure on the payers to pay for it. I mean, I hope that Medicaid continues to pay for it. I hope Medicare continues to pay for telehealth. I think a lot of these things are made in these sort of bastions, not Medicaid, obviously, but Medicare for sure, made in these bastions of healthcare like Boston and Chicago and New York City and Philadelphia, where they do not have the rural spread that we have. They don't recognize what a strain it is on patients. A 75-year-old person with 3 or 4 chronic conditions in the middle of, Carnegie, Oklahoma, could spend a fair amount of time in their car going back and forth to see all their specialists. It's not like it is in New York City. We just got to jump on the A train. I mean, it's telehealth is a big deal, and I hope that they continue to respect that. And I do think it's had a very positive impact on care. Yes, I recognize you can't do a colonoscopy over the internet, but you can do.
No, you can't. No, you can't. Let's not go there.
All right.
All right.
By the way, we have a winner. Are we ready to name the winner?
Sure.
Did somebody guess the right number?
Yes, they did.
Really?
Somebody's cheating.
Mark Ellis said 55.
Wow.
Now, did you just come right up? Did you point figure on that one? I'll go down here and see if he responds. Mark Ellis is our winner.
55.
I didn't say, cheating's okay on it.
Send him another, brother.
That's right.
We will get that. All you got to do is send me a message and we'll get you that Nutter Butter courtesy of OBI.
OBI.
Yeah. And also had to say you have to go donate too.
Yeah.
To get that. So these are really good questions. We can do a show based upon what we've been asked here tonight on telehealth, telemedicine, how to screen, all of these things, doctors. We could do that one. So, and back to you, doctor.
All right.
All right. Well, I'm willing to do it. I think we need to be answering the questions that people have out there for many reasons, but that's the purpose of the show, is to try to get accurate scientific information to the people. So if they have a question, we need to be answering it. I don't really have anything else at this time. Dwight, David, it's been an hour. Do you have anything more that you think is important to bring up tonight?
Go get your flu vaccine.
Yeah, get
Don't forget
get
about the-
vaccinated. That's the
don't forget
biggest
about the
thing
other
right
one.
now.
If you've been vaccinated, get your booster.
Get your booster.
I did the Moderna. Trust me, it's no big deal.
Not a big deal at all.
So, but you do have to be careful. Don't do what I did. I thought I made an appointment for a Moderna vaccine, showed up at the pharmacy that I was getting it at, and got informed, well, we only have Pfizer here. Well, that's not what the website said. So we had to make a second appointment at another place.
Yeah.
So make sure if you want one or the other,
The good news is you can mix and match now.
you can mix
You
and
can
match.
Mix and match.
I had Moderna. I just wanted to stay with the same.
Yeah.
And, that's the right of the people. But you got to be careful. Make sure that where you're going, they have what you want. So,
And for the kids, for the 5 to 11 age group, it looks good as far as very little side effects. Safety is good. Get the vaccine for the kids for the COVID and the flu and the routine vaccines. Yeah.
and important last comment, the Moderna vaccine for kids,
Mhm.
they've put off until January,
Yeah.
even making a decision on it. So, go get
It's
your
okay.
Pfizer vaccine for the
Pfizer.
kids. That's
Mhm.
right.
Pfizer.
Go get it.
Go get it.
So, by the way, for Mark, send me your address, scott@mitchelltalks.com. We'll get that nutter buttered to you.
Oh, absolutely.
Absolutely. We will do that.
Absolutely.
And thanks for all the questions. We'll take these. We'll do a show based upon these questions, because the money that's being loosed, even though our delegation voted against all of it, they still going to get to spend it. So it'll be interesting. That's going to be an interesting question. It's kind of like, you're not going to send the money back, are you? I don't think that they would
no.
answer it. Yes.
I don't think they will.
That doesn't happen. No.
All right. Thanks to all the people that watch every Monday night. We appreciate you. Thanks to News 9 News on 6, as always, for streaming this. And we'll see you Wednesday night. We'll spend a little time on this, especially on the aspect of the jails. And we'll stay on this topic for a few weeks. Have a great weekend. Have a great week. We'll see you Wednesday night. Goodbye, everyone.
And happy Thanksgiving to everybody.
Happy Thanksgiving.
Thanksgiving.